Hello everyone, this is Ashraf Hassanpour from Shiraz University of Medical Sciences, Anatomical Department. Welcome to this set of lectures where we are going to be talking about the neck anatomy. In today's lecture, we are going to be looking at the sum of general aspects and neurovasculature of the neck. The neck or cervical region is perhaps one of the most anatomically complex regions of the body. Despite being a relatively small region, the neck certainly packs in a large amount of the structures such as muscles, blood vessels, and nerves. In anatomy, the neck is also called by its Latin name, cervix, and term cervical means of the neck. Let us start off with the surface anatomy of the neck. The neck is more or less cylindrical structure connecting the head to the trunk. Anteriorly, it extends from the inferior border of the mandible to the superior surface of the manubrium, and laterally along the clavicles to the point of the shoulders or acromion. Posteriorly, it is bounded inferiorly by a somewhat irregular surface described by an imaginary line drawn between the right and left acromions that passes through the intervertebral disc between the seventh cervical and first thoracic vertebra, and superiorly by the superior nuchal line and external occipital protuberance of the occipital bone. The anterior midline of the neck presents a bulge whose size reflects sexual dimorphism in that it is considerably larger in males than in females. This prominence is Adam's apple, that is officially named the large prominence of the thyroid cartilage. Between the Adam's apple and the chin, the hyoid bone can be felt. Below the thyroid cartilage, a further ring that can be felt in the midline is the cricoid cartilage. Between the cricoid cartilage and the suprasternal notch, the trachea and isthmus of the thyroid gland can be felt. The inferiormost region in the midline of the anterior neck is the jugular notch or suprasternal notch of the manubrium. Tensing the neck relieves the bellies and the tendons of the origin of the sternocleidomastoid muscle just lateral to this notch. This muscle may be palpated along its entire length as it passes posteriorly and obliquely to insert on the mastoid process of the temporal bone and superior nuchal line of the occipital bones. By pressing the jaw laterally against the resistance of one's hand, the opposite sternocleidomastoid is tensed. The posterior aspect of the neck is composed mostly of muscle masses on either side of the spinous processes of the cervical vertebrae. The muscle masses are more probably considered to be the deep muscle of the back because they function in addition to supporting the head in the extension of the atlanto-occipital and other vertebral joints. These muscle masses are covered by the trapezius muscle, which contributes to shaping the posterior aspect of the neck. The skin covering the neck is arranged in such a fashion that longer lines run almost horizontally around the neck. This is important clinically because an incision along a cleavage line will heal as a narrow scar, whereas one that crosses the lines will heal as a wide or heaped up scar. Now let's go from superficial to deep. Deep to the dermis is a very thin facial layer consisting of an areolar or loose type of connective tissue known as the hypodermis or superficial fascia with varying amounts of adipose. This superficial fascia envelopes the neck just as the overlying skin does, and contains within it a paper-thin sheet of the skeletal muscle, the platysma. Platysma muscle is a muscle of facial expression with a primary action of neck tension and also plays a role in a weak depression of the mandible and lower lip. Violently clench the jaws. This muscle then comes into view as a sheet of muscle passing from the mandible down over the clavicles, lying in the superficial fascia of the neck. The platysma muscle, like all muscles of facial expression, is innervated by the facial nerve, specifically the cervical branch. The superficial venous drainage consists of the external jugular vein and its tributaries, which drain a limited area of tissue. The external jugular vein is formed by the union of the posterior auricular and retromandibular veins just posterior to the angle of the mandible, sometimes within the body of the parotid gland. It passes straight down the neck under the cover of the platysma muscle and associated superficial fascia, superficial to the fleshy belly of the sternocleidomastoid muscle. In its path along this muscle, the external jugular vein crosses the muscle at an oblique angle. Once the external jugular vein reaches the subclavian triangle, it dives deep to the clavicle to join the subclavian vein. Several tributaries join the external jugular vein along its path. Another superficial vessel, the anterior jugular vein, occasionally empties into the external jugular vein, but usually it joins the subclavian vein directly. The anterior jugular vein communicates with its corresponding vein on the other side via a venous connection, the jugular arch, which occupies the supraesternal space. It must be kept in mind that venous drainage exhibits great variability in vessel size and routes of distribution. External jugular vein is seen from the audience when a singer hits a sustained high note, and when clinical factors such as chronic lung disease, mediastinal tumors, or infections impede the flow of the blood to the right heart. Blood dams up in the superior vena cava and consequently the jugular vein. This causes conspicuous swelling in the jugular veins. Alright, next stop in this journey of the neck is to look at the deep fascia and cervical compartments. Deep fascia is typically denser than the superficial fascia and is devoid of adipose tissue. This fascia is important in the surrounding and supporting muscle, organs, and neurovasculature. In certain areas, deep fascia is condensed to form well-defined fibrous sheets called the investing layer, the pretracheal layer, and the perivertebral layer. It is also condensed to form the carotid sheet. An investment of the fascia derived from the component layers of deep fascia surrounds the large vessels and nerves that pass between the trunk and the head. The investing layer, also known as the superficial layer of deep fascia, surrounds the neck, and as the name suggests, this layer invests entirely of the neck deep to the skin and superficial cervical fascia. It's attached to all the bony landmarks of the upper and lower margin of the neck. Investing fascia splits into two laminae to invest or sandwich the sternocleidomastoid, trapezius, and the strap muscles. Here it also splits to enclose the submandibular gland and to form the fibrous capsule of the parotid glands. As we saw earlier, the external jugular vein pierces the deep fascia above the clavicle. If the vein is divided here, it is held open by the deep fascia which is attached to its margin. Air is sucked into the vein lumen during inspiration, and a fetal air embolism may ensue. The prevertebral fascia passes across the vertebrae and prevertebral muscles behind the esophagus, the pharynx, and the great vessels. Above, it's attached to the base of the skull. Laterally, the fascia covers the scalene muscles and the emerging brachial plexus and subclavian artery. These structures carry with them a sheath formed from the prevertebral fascia, which becomes the axillary sheath. Inferiorly, the fascia blends with the anterior longitudinal ligament of the upper thoracic vertebrae in the posterior mediastinum. Pus from a tuberculous cervical vertebrae bulges behind this dense fascial layer and may form a midline swelling in the posterior wall of the pharynx. The abscess may then track laterally deep to the prevertebral fascia to a point behind the sternocleidomastoid. Rarely, pus has tracked down along the axillary sheath into the arm. And finally, the perithecal fascia. The perithecal fascia encloses the visceral compartments of the neck, extending from the hyoid above to the fibrous pericardium below. It encloses larynx and trachea, pharynx and esophagus, and the thyroid gland. A separate tube of fascia forms the carotid sheath, containing carotid artery, internal jugular vein, and vagus nerve, and bearing the cervical sympathetic chain in its posterior wall. So, as you saw, the structures of the human neck are anatomically grouped by dense layer of deep fascia into four spaces or compartments. Vertebral compartment contains cervical vertebrae and postural muscles. Visceral compartment contains glands, thyroid, parathyroid, and thymus, the larynx, pharynx, and trachea. Two vascular compartments contain the common carotid artery, internal jugular vein, and the vagus nerve on each side of the neck. And here you can see the retropharyngeal space. It's a potential space posterior to the muscular wall of the pharynx and its investing buccopharyngeal fascia, anterior to the prevertebral fascia, and spanning the distance between the base of the skull and the mediastinum within the thoracic cavity. The retropharyngeal space communicates laterally with the parapharyngeal space. Clinically, the retropharyngeal space is important because it represents a potential pathway for metastasis of disease between the head, neck, and the thorax. Now, we are going to be talking about the neurovasculature that we find in this area of your body. I would like to start off with the common carotid arteries. These are the biggest and most important arteries of the neck, and one of them, the left one, is coming out of the aortic arch, while the right one is branching out of the brachiocephalic trunk. So, these two arteries supply the major part of the head and neck with arterial blood. The common carotid artery runs upward through the neck under cover of the anterior border of the sternocleidomastoid muscle from the sternoclavicular joint to the upper border of the thyroid cartilage. Here, it divides into the external and internal carotid arteries. At this point of division, the terminal part of the common carotid artery, or the beginning of the internal carotid artery, shows a localized dilatation called the carotid sinus. The tunica media of the sinus is thinner than elsewhere, but the adventitia is relatively thick and contains numerous nerve endings derived from the glossopharyngeal nerve. The carotid sinus serve as a reflex pressure receptor mechanisms. A rise in blood pressure causes a slowing of the heart rate and vasodilatation of the arterioles. External massage called the carotid sinus massage can be used to slow the heart rate and decrease the blood pressure for diagnostic purposes and in emergency cases of supraventricular tachycardia. An additional structure, the carotid body, is also associated with this region of bifurcation. This small oval reddish-brown structure lying within the internal carotid artery is innervated by the vagus and glossopharyngeal nerves. The carotid body functions as a chemoreceptor, monitoring oxygen and carbon dioxide tension as well as hydrogen ion concentration within the internal carotid artery. The internal carotid arteries do not supply any structures in the neck. So, let's take a look at the external carotid arteries, which lie laterally from the internal carotid artery and then supply most of the parts that we find on the neck, face, skull, and also dura mater. The external carotid artery has 6 collateral and 2 terminal branches. Branches of the external carotid artery that supply regions of the neck are treated for now. However, branches concerned with the superficial and deep face will be discussed in the appropriate lecture. So, the superior thyroid artery is the first branch of the external carotid artery arising from its ventral aspect just superior to the bifurcation of common carotid artery. The superior thyroid artery descends in the neck accompanied by the same name vein and external laryngeal nerve. It reaches the superior pole of thyroid gland and divides into its terminal branches. The next one is ascending pharyngeal artery. It is the smallest branch of the external carotid artery. It arises on the medial aspect of that artery shortly after the bifurcation of the common carotid and ascends between the internal carotid and the pharynx. The ascending pharyngeal artery has unnamed muscular branches to the prevertebral muscles as well as branches supplying additional structures in its vicinity. Another important artery that we see here near the posterior tip of the greater horn of the hyoid bone is lingual artery. This artery often arises in common with the facial artery, then becoming the faciolingual artery, and passes deep to the hypoglossal nerve to supply the muscles of tongue and some other structures of mouth like sublingual gland and tonsils. The occipital artery originates on the posterior aspect of the external carotid artery, just opposite the origin of the facial artery. It passes posteriorly to serve the back of the head. Finally, the posterior auricular artery is a small branch arising deep to the parotid gland where it passes between the mastoid process and the external auditory tube. It supplies the parotid gland and the sternocleidomastoid, stylohyoid, and digastric muscles. Next set of arteries that we are going to cover are known as thyrocervical trunks, another arterial system for the neck besides the carotid arteries. The thyrocervical trunk is a short vessel arising from the superior aspect of the first part of the subclavian artery and then quickly split up into 3 branches: the suprascapular, transverse cervical, and inferior thyroid arteries. The inferior thyroid artery travels superiorly and approaches the inferior aspect of thyroid gland, where it is closely related to the recurrent laryngeal nerve. It supplies the thyroid and the inferior parathyroid glands. The transverse cervical artery crosses the neck and supplies a few structures including trapezius and rhomboid muscles as well as part of cervical lymph nodes. The suprascapular artery runs laterally over the brachial plexus and it supplies the posterior shoulder area. Next arteries that we are going to be seeing here are known as the vertebral arteries. The vertebral artery is the third big arterial system of the neck besides the carotid arteries and thyrocervical trunk. These begin as a branch of subclavian artery and run vertically up the neck through the foramina in the transverse processes of upper 6 cervical vertebrae, and then they go into the head and essentially are responsible for the blood supply of the brain as the basilar artery. Now we are going to move on and talk about two sets of jugular veins, the external and the internal jugular veins. On the left side, we are looking at the external and anterior jugular veins that we have discussed before, while on the right side, we are looking at the internal jugular veins. The internal jugular vein is a large vein that receives blood from the brain, face, and neck. It starts as a continuation of sigmoid sinus and leaves the skull through the jugular foramen. It then descends through the neck in the carotid sheath lateral to the vagus nerve and internal and common carotid arteries. It ends by joining the subclavian vein behind the medial end of clavicle to form the brachiocephalic vein. The vein has a dilatation at its upper end called the superior bulb and another near its termination called the inferior bulb. During its descent down the neck, the internal jugular vein receives blood from the facial, lingual, occipital, superior and middle thyroid veins. These veins drain blood from the anterior face, trachea, thyroid, esophagus, larynx, and muscles of the neck. Now, let's move on to discuss some nerves that we find on the neck region. Let's start off with the very famous one that you see here. The vagus nerve is also known as the syncranial nerve. The fibers of the vagus nerve consist of efferent or motor fibers and parasympathetic fibers and afferent sensory fibers. In the neck, the vagus nerve passes into the carotid sheath, traveling inferiorly with the internal jugular vein and common carotid artery. At the base of the neck, the right and left nerves have different pathways. The right vagus nerve passes anterior to the subclavian artery and posterior to the sternoclavicular joint, then entering the thorax. The left vagus nerve passes inferiorly between the left common carotid and left subclavian arteries posterior to the sternoclavicular joint, then entering the thorax. Several branches arise in the neck. Pharyngeal branches provide motor innervation to the majority of the muscles of the pharynx and soft palate. Superior laryngeal nerve splits into internal and external branches. The external laryngeal nerve innervates the cricothyroid muscle of the larynx, and the internal laryngeal provides sensory innervation to the laryngopharynx and superior part of the larynx. And finally, right and left recurrent laryngeal nerves. Right recurrent laryngeal nerve hooks underneath the right subclavian artery, and left recurrent laryngeal nerve hooks under the arch of the aorta. Both ascend to innervate the majority of the intensing muscles of the larynx. The glossopharyngeal nerve descends down the neck anterolateral to the internal carotid artery. It has several branches to provide motor innervation to the muscles. It also gives rise to the carotid sinus nerve, which provides sensation to the carotid sinus and body. The nerve enters the pharynx by passing between the superior and middle pharyngeal constrictors. Within the pharynx, it terminates by dividing into several branches, lingual, tonsil, and pharyngeal, and innervate these structures. Here you can see accessory nerve. The accessory nerve is the 11th paired cranial nerve. It has a purely somatic motor function, innervating the sternocleidomastoid and trapezius muscles. The hypoglossal nerve is the 12th paired cranial nerve. Its name is derived from the ancient Greek, hypo meaning under and glossal meaning tongue. The nerve has a purely somatic motor function, innervating all the extrinsic and intrinsic muscles of the tongue. Extracranially, it passes inferiorly to the angle of the mandible, crossing the internal and external carotid arteries and moving in an anterior direction to enter the tongue. Next structures that we are going to be seeing here are known as the cervical sympathetic trunks. The cervical sympathetic trunk is the cervical continuation of the thoracic sympathetic trunk. It consists of 3 ganglia connected to each other by short cords. The superiormost of these is the superior cervical ganglion, located at the level of the axis and 3rd cervical vertebra. The middle cervical ganglion, the smallest of the 3, lies at the level of the 6th cervical vertebra. The inferior cervical ganglion, located at the level of the 7th cervical vertebra, is often fused with the 1st and infrequently with the 2nd and even 3rd thoracic ganglion, then named the stellate ganglion. Most postganglionic nerve fibers to the head and neck arise from one of these ganglia. The cervical sympathetic trunk is embedded in a loose connective tissue layer and positioned between the covering of the prevertebral muscles and the carotid sheath. The final structure that we are going to look at here is the cervical plexus and some of the nerves arising from this plexus. The cervical plexus is a cluster of nerves formed by the ventral rami of the first 4 cervical spinal nerves, C1 to C4. In some textbooks, you may find that the 5th cervical nerve is included in the cervical plexus due to the fact that it contributes to the formation of the phrenic nerve, which is one of the motor branches of the cervical plexus. The cervical plexus gives off both muscular branches, which are the anterior branches, and cutaneous branches, which are the posterior branches. As you can see, right below the cervical plexus, there is another important plexus, the brachial plexus, which is responsible for cutaneous and muscular innervation of the entire upper limb. But for now, we are going to focus on the cervical plexus. We will look at the sum of the branches of the cervical plexus as well as the spinal nerves that contribute to its formation. Let's start by the first looking at the muscular or deep branches of the cervical plexus. The nerve seen here is a very important nerve known as the phrenic nerve. In this image, we can see the phrenic nerve running across the surface of the anterior scalene muscle. The phrenic nerve arises from the 4th cervical spinal nerve, but also receives contributions from the 3rd cervical spinal nerve and the 5th cervical spinal nerve. Therefore, we can say that the the phrenic nerve receives innervation not only from the cervical plexus but also from the brachial plexus. The phrenic nerve contains motor, sensory, and sympathetic nerve fibers. As I said earlier, the phrenic nerve crosses the anterior scalene muscle when entering into the superior thoracic aperture in front of the subclavian artery and travels to the middle mediastinum to reach the diaphragm. It is supplying motor innervation to the diaphragm and sensory innervation to the central tendon. The phrenic nerve also gives off sensory branches that supply the precardium. They are known as the precardial branches. Another important muscular branch of the cervical plexus is this structure seen here, known as ansa cervicalis. The term ansa cervicalis is Latin for the handle of the neck. It is a loop of nerves formed by the anterior rami of the cervical spinal nerves C1 to C3. The ansa cervicalis is formed by a combination of the superior root of the ansa cervicalis and the inferior root of the ansa cervicalis. The superior root, which is also known as the anterior root, is formed from the cervical spinal nerve C1, whereas the inferior root, also referred to as the posterior root, is formed from the second and third cervical spinal nerves. The branches of ansa cervicalis mainly supply innervation to the infrahyoid muscles. Here I just want to show you a list of motor branches of ansa cervicalis. One of the branches is the geniohyoid nerve from C1. Geniohyoid is the only suprahyoid muscle that ansa cervicalis supplies. The other branches supply the infrahyoid muscles such as thyrohyoid from C1, omohyoid from C1 to C3, sternohyoid also from C1 to C3, and sternothyroid from C1 to C3. These nerve branches supply motor innervation to their corresponding muscles. Now that we've covered ansa cervicalis, let's look at this nerve, which is not part of the cervical plexus but is closely associated to it. The nerve we are talking about is the hypoglossal nerve. As I mentioned, the hypoglossal nerve is the cranial nerve 12. It exits the skull via the hypoglossal canal and courses downwards. As it completes this descent and begins to pass forward across the internal and external carotid arteries, some fibers join with the fibers of the C1 nerve and form the superior root of the ansa cervicalis. These fibers finally innervate the geniohyoid and thyrohyoid muscles. So, in this way, the hypoglossal nerve is related to and form anastomosis with the cervical plexus. Please keep in mind that the main branch of the hypoglossal nerve continues and innervates the thyroid muscle with fibers from the first cervical spinal nerve. This is before it goes on to innervate some of the extensing and intensing muscles of the tongue. Another important communication of the cervical plexus is with the 11th cranial nerve or the accessory nerve. This nerve is a motor nerve and innervates sternocleidomastoid and trapezius muscles. It receives a branch which is known as the branch tube trapezius and originates from the cervical plexus, namely C2 and C3 cervical nerves. So in this way, the cervical plexus anastomoses with the accessory nerve and contributes to innervation of the trapezius muscle. I would like to mention here that the cervical plexus gives off several other muscular branches that supply some of the prevertebral and lateral vertebral muscles in the neck. These muscles include rectus capitis anterior, rectus capitis lateralis, longus coeli, and longest capitis. So far, we've looked at the deep branches of the cervical plexus, which are mainly motor branches. Now, let's move on to look at the cutaneous branches of the cervical plexus that are sensory nerves. There are 4 sensory branches, namely the lesser occipital nerve, the greater auricular nerve, the transverse cervical nerve, and the supraclavicular nerves. Here we can see the lesser occipital nerve, which is the uppermost of the sensory or cutaneous branches of the cervical plexus. It is formed from the loop of the ventral rami of the second cervical nerve, and it passes upwards at the posterior margin of the sternocleidomastoid. The lesser occipital nerve supplies the skin of the neck and the scalp posterior to the auricle of the ear. The transverse cervical nerve, or the anterior cervical cutaneous nerve, consists of branches from the cervical nerves C2 and C3. The transverse cervical nerve horizontally crossing the sternocleidomastoid to supply the anterior and lateral parts of the neck. The supraclavicular nerves are other sensory branches of the cervical plexus. They arise from the loop between the third cervical spinal nerve and the fourth cervical spinal nerve as a common trunk under the cover of the sternocleidomastoid. The supraclavicular nerves are cutaneous branches that are spread out fanning around the shoulder and clavicular regions. Another sensory or cutaneous branch of the cervical plexus is the great auricular nerve. It originates from the second and third cervical spinal nerves and courses upward crossing sternocleidomastoid onto the parotid gland. Here, the great auricular nerve divides to innervate the skin over the parotid gland, the posterior aspect of the auricle, and the mastoid area. And also important to mention that sensory branches of the cervical plexus merge at the dorsal edge of the muscle at the Erb's point or punctum nervus. It can be used as a puncture area for local anesthesia. Okay, before we finish this lecture, I'd like to briefly mention that the first 3 cervical spinal nerves along with the 4th cervical spinal nerve receive communicating fibers that are contributions from the sympathetic trunk to the cervical plexus. So now we've reached the end of the lecture. Thanks for watching. Good luck everyone.